Good afternoon, everyone. On behalf of Association of Clinical Biochemists of India, I extend a very warm welcome to everyone. And as members of ACBI, it is an enterprise to create the awareness about the latest updates in clinical biochemistry and to enhance the academic activities. And this is one of the steps towards it. So before we begin our session, we are fortunate to have our current president of ACBI, Professor Indu Verma, with us. So I request Professor Indu Verma to please formally welcome all the delegates who have attended this, who are part of this first session of this e-webinar series. Over to Dr. Indu Verma.
Thank you, Dr. Mamta. Good afternoon, everyone. This is really a great initiative, having this webinar on behalf of ACBI, and I welcome you all. ACBI has always worked for the health of mankind, particularly through improving the science and clinical practice, particularly in the laboratory medicine. And this webinar is one step towards that direction. The topic of today's webinar is role of laboratory medicine in improving diagnosis, which is a very pertinent theme, particularly considering that accurate and timely diagnosis is very important for the patient care. And this webinar will create a special you can say, a platform where clinicians can interact with the laboratory personnel and can really help to improve the patient care. So I'm really happy that this is a really a great step. And in this webinar, we have first talk by Dr. Seema, who will be speaking on improving quality of diagnosis, a pre-analytical journey, highlighting the significance of meticulous pre-analytical processes, particularly in ensuring that accurate results are delivered from the laboratory to the clinics. And the second lecture is on the interaction of clinicians with laboratory, a mode of enhanced patient care, which I feel is really very important, particularly to convey that how laboratory medicine is important for the patient care. So I encourage active participation from all the attendees, and I am very confident that today's discussion will provide a valuable insight and a valuable platform for future collaborations between scientists, laboratory people, and clinicians. So welcome you all, and over to Dr. Mamta.
Thank you, Dr. Indu, for such a very encouraging and very warm welcome address to everyone. And this is the best part of ACBI, that they have a very inclusive approach, and focus is on the academics, and especially focuses on young scientists, also young researchers and all. So before we begin this webinar, I have prepared a brief introduction about the ACBI, what activities are being done under ACBI for so many years, so that all our audience who are not aware about the activities in detail, they will also be apprised about these things. So ACBI, as Association of Clinic, is my screen visible to everyone?
Yes.
So ACBI, basically it was a history in January January 1975 was a red letter day for the clinicians of just a minute. For clinical biochemistry, when renowned clinical biochemists from all parts of the country resolved to establish the Association of Clinical Biochemistry of India. Reason: to promote improvement in the health and well-being of the communities by holding meetings, congress, seminars, symposia, and to organize and establish institution training centers. So aim and objectives: to create the awareness on importance of biochemical test in preventive, curative, and rehabilitative healthcare, and to advise universities, governments, and statutory authorities regarding biochemistry, including clinical biochemistry. Publish journals related to clinical biochemistry and news bulletins. So basically to create all the academic activities. And since then, the annual conferences have been held in various parts of the country. And we also have association with international and national organizations such as IFCC, APFCB, INSA, NAMS, QCI, ICHA, etc. And the notable milestones and achievements were: at the behest of the association, the Medical Council of India recommended separation of biochemistry subject and the Department of Biochemistry from those of Physiology. And a separate paper of Biochemistry was introduced at the first MBBS examination from 1977. And in ACBI, we have ACBI Council, the Executive Committee. And as I said, this is a unique platform to interact with clinical biochemists, not only from India, but from abroad as well. And by ACBI organizes its national conference once in a year, and each time it is in a different city of the country. And it is a unique opportunity to get the upgraded knowledge, and especially for young members for whom it provides an opportunity for academic exposure. And being a member of ACBI, it's open to teachers, researchers, clinical scientists. So basically, qualification in biochemistry, clinical biochemistry, immunology, these are the various qualifications who are eligible to be member of ACBI. And if the above categories of the qualification are not fitting into that criteria, then the founder member, then they can become an associate member. And as I said in the previous slide, that being an ACBI member, we automatically become full member of IFCC, then APFCB, and also of World Association of Societies of Pathology and Laboratory Medicine, that is WASPAM. This provides a unique opportunity to be part of many programs, and one of the notable ones is IFCC Professional Exchange Program, in which we can go to other institutes to get the learning, and similarly, we can invite people to our institute to update and upgrade their knowledge. One of the very important part of ACBI is that they started this journal, Indian Journal of Clinical Biochemistry, which is a PubMed Index International Journal. Editor-in-Chief, Dr. Praveen Sharma, who is with us. And this is published 4 times a year from January, April, July, and October. And in this, original research work of Indian and foreign scientists related to clinical biochemistry is published, as well as review articles, short communications, case reports, and proceedings of special symposia. Journal is abstracted by chemical, abstract, etc., medical, and many others. And this journal is free for all life members and the corporate members. And this is also available online. And in addition to this, ACBI also published a news bulletin, which is available on their website. And this has all the academic activities of the year. Another flagship program under ACBI is the ACBI CMC Valor Quality Control Program, which started in 1977 only. The Executive Council of ACBI wanted to start because an equa for Indian laboratories, and Dr. Kanak Sabapati, who is now not with us, but he was the pioneer in this, and he basically based at Christian Medical College. And he took that challenge and did a pilot study along with Dr. Peter Hill and Dr. S. Swaminathan, and started with a small pilot project. Then it took included 58 laboratories, and now we can see that it has crossed almost many thousands. It has become now, and initially it was bovine sera for many years. Now it is human sera based, and the technologies have advanced. And after Dr. Kanak Sabapati retired, and these are the people: Dr. Selva Kumar, Dr. Victoria Job, Dr. Gitanjali, and now Dr. Pamela Cristidos is contributing to the growth of this program. And I will not go into details, but there are various programs available. And being a lab person, I can tell that wherever you go in India, most of the labs are using this program, which is under the flagship of ACBI. Then we also have another important program under ACBI, that is membership of Indian Board of Clinical Biochemistry. And because this is a course of clinical biochemistry is not available anywhere in India. As in other countries, they give MRCP, FRC, PET, etc. So this is initiative which is taken by ACBI, and ACBI set up the Indian Board for Clinical Biochemistry. And those who are undergoing regular MD or MSc PhD courses can also take up this course as it helps in their studies. And this is approved by Quality Council of India. Eligibility: any candidate who is doing MD biochemistry or has done MD biochemistry or with PhD in biochemistry, or any candidate with MBBS. So all details you can find on the website. And why you should do this course is very important, because during our academic curriculum and all, the nitty-gritty of the working in the clinical biochemistry lab many a times is not taught. So this gives you basic idea how to perform the medical biochemistry techniques and perform only clinical laboratory practices. Post duration is 3 years, and it has teaching faculty from very senior faculty from various institutes all over the India. And it has dissertation also. People with MD who have done MD and PhD, they are exempted from this. and it has a carryover system also due to some reason if it is not able to complete their course in that duration. So it has some grace period also. Another important facility which is provided by ACBI is travel fellowship and awards. And this is again to encourage young people to be part of this. Age limit is below 35, ACBI travel fellowship, and then we have fellowship award. Then there are various oration awards which are given at the time of their annual conference, which is being hosted every year in a very premier institute. So most notable one is, I will name few. Otherwise, rest of the details are available on the website. Abdesharan Memorial Oration Award, St. GS Medical College and KEM Award, KL Gupta Memorial Oration, Dr. T.N. Pattabhiraman Oration Award, Mrs. and Dr. G.P. Talwar Oration, K.P. Sinha P.S. Krishnan Award, Dr. Tarana Shetty, and there are many more, Dr. Praveen Sharma Oration, and Rita Bas Jamna. So, as you can see, the Council of ACBI has organized so many programs to encourage people to be part of the research and to publish and present their work. So PS Murthy Award, so these are the various awards. And as I said, various academic activities are conducted. So the latest one is being hosted by South Zone. And this is tomorrow only. And another major activity which is being conducted with ACBI Con only, 34th Vastam and 51st ACBI Con 2025 in Pune. And another flagship event is in 2026, which is IFCC World Lab New Delhi, being hosted in New Delhi only in 2026. So we request all of you be to part of it. And all the details are available on the website. I have just introduced what are the major events which ACBI has been doing, and they are encouraging everyone to be part of it. And thank you very much. So now I invite Professor Seema Bhargav, who is Chairperson and Senior Consultant, Department of Biochemistry. She is also Professor Gripmar, Gangaram Institute of Postgraduate Medical Education and Research. She is also past President of ACBI and members of many societies. So without taking more time, I'll hand over to Dr. Seema Bhargav.
Are we audible? Am I audible?
Yes, yes, madam.
Okay. This is not full screen, na? No, it's not. Is it? Is it full screen mode? Yes. Please let me know if it is.
Ma'am, you have shared the Chrome browser. You have to share the PowerPoint, not the.
Yeah, let me just do that. Now, where is the PowerPoint? Just 1 minute. Just give us a minute.
You need to stop share and do a new share. And while sharing, make sure that you share the PowerPoint.
Come through my own system. And I'm joining Mamta here. And thank you very much for including me amongst the first speakers in our program that this is the first of the series that we're starting. And we hope that with the encouragement and help and input of all members of ACBI, we will be able to really make a difference and help everyone around. And the topic we chose is where things start in the lab, and that is improving quality of diagnosis, a pre-analytical journey. And all of us know the brain-to-brain loop, and I don't really need to talk about it. All I want to emphasize is that though analytical, the errors that occur in this phase, analytical phase is 6 to 15%, and post-analytical is 18 to 30. It is the pre-analytical and the pre-analytical which starts from the patient being seen by the doctor to the time that the sample is pre-processed before being put on, before being analyzed. And that area takes up 62 to 76% of our causes errors. And as you all know, analytical errors are very visible and they're addressed easily. Post-analytical errors are not so visible, but still they are, one is able to address them. It is only the pre-analytical and the pre-analytical errors that are deep-seated and elusive and often unaddressed as they remain undetected. This is a listing of the various types of errors that may occur, whether it is an inappropriate test request or an order entry mistake or a patient sample misidentification or a problem in sample collection, whether clotting has happened, hemolysis has happened, improper volume has been taken, or sample is collected from an infusion route. There are many such things, and all of these come under pre-analytical. I will focus on a few of them just to give you a direction in which to go. And so what is the responsibility? Whose responsibility is it? First and foremost, I would think it is the clinician's responsibility, who must inform the patient as well as the phlebotomist that whether he wants a fasting sample, whether he wants a trough sample for the patient, whether it's a timed sample. For example, for endocrinology, they require timed samples for ACTH and for cortisol. So all these things have to be explained by the clinician to the doctor, and the phlebotomist must also know. Of course, the nursing staff and the phlebotomist have to be very well versed with each and every part of the required procedures. And I'll come to that later. It looks very simple. It's not that simple. The patient should be again adequately instructed, and he has to also be instructed about whether or not he should take any exercise, whether he should be exercising while doing this. And of course, the laboratory personnel who are actually going to receive the sample and process it before it goes onto the analyzers or into manual procedures. And therefore, all of them have to work together, and it is best to have an SOP for this, which should be part of your sample collection manual. The phlebotomy procedure looks very simple, but it requires meticulous planning, adherence to infection control measures, and patient-focused care, ensuring accurate blood collection, staff safety, and overall healthcare quality. And these are just a few pointers here listed that can affect the way you take the sample, and that can affect the sample in the long run. So therefore, and the reporting. So this, I've just listed a few here, whether it is putting together the correct items, whether it is making sure that you identify the patient correctly, whether it is assembling the needle holder properly and there is no leakage there, whether it's inserting the needle at the proper angle. There are so many things that the phlebotomist has to look at. And as they get practice, they do well, but they must remember each of these things every day, every time they do a phlebotomy. And what are the good phlebotomy practices? As I said, this is about having the correct, you match the list with the tubes that you have to take. So you know that glucose can be taken only in the gray top. Serum, if you require a serum sample, it has to be a yellow top. All of that is the phlebotomist's job. And therefore, appropriate preparation of the patient, correct method of collection of each specimen, and any special handling in terms of whether the sample has to be immediately taken to the lab or it can be delayed, or whether you want the sample to stand, because the serum sample you'd like to stand before you send it anywhere. You don't want it to get hemolyzed. So amongst the various pre-analytical errors, we find that hospital improper billing is one of the major ones. Our hospital system is that we have a billing through the hospital information system. There a barcode is generated, and then the sample is drawn and sent to the lab. So in this process, we often get problems because sometimes a sample comes with a kidney function test and also calcium. A patient is billed for this, an anemia profile as well as iron, TIBC, and ferritin. Now that means that the person who is drawing the sample or who is doing the billing does not know what is the inclusion in each profile or each test. So because of that, and there are, of course, in different institutions, you have different inclusions in these KFT. Some people write only BO and creatinine, sodium and potassium. Whereas in our hospital includes BO and creatinine, sodium, potassium, chloride, bicarbonate, calcium, phosphorus. So therefore, unless you know your system, in your own hospital or your own institute or your own lab, you might make a mistake in this. So an example is like this. We had this anemia profile, and the billing came like this with iron binding capacity, iron, ferritin, as well as anemia profile. So this was wrong billing. So what is the solution? Of course, very simple. It sounds simple. Training. Training, and training is what I find is what helps us the most. Induction training of nursing staff and residents with periodic repetitive training. And then the directory of services also should be available to everyone and accessible to everyone within the hospital. Whoever wants to view it should be able to view it at the click of the mouse. And we do have that system here. And of course, the ordering physicians must also be aware of it and aid, because they're so busy, they're looking after so many patients at a time. Sometimes they miss what is happening in their own hospital. So it is good to send them reminders of whatever profiles and panels you have. And if they have a ready reckoner in front of them, it makes it easy for them to order the correct tests. And that just shows that it means you have to have a coordination between nursing staff, residents, laboratory physicians, as well as ordering physicians. So what is the another problem can be improper placement of the barcode. One is the most important thing is that it should be placed parallel to the label and straight. It should not cover the area where there is where the batch number and expiry data mentioned, because that has to be visible. And it should leave at least 1 inch area below the below the sample. Sorry, the label should be 1 inch from the bottom of the tube, because almost all analyzers have samples, and those sample racks cover this area, and therefore the barcode does not get read properly. So these are the small pointers, but important when you're day-to-day functioning. So let me talk about a sample that was received by us for serum phenytoin from the OPD at 11 a.m. Before processing, we decided we should request the drug history. Now, because we know that phenytoin dosage is 300 milligram once a day or 100 milligram 8 hourly. And trough level is measured just before the next dose, while its peak level is measured 1 week after institution of treatment or 2 hours after an IV bolus. Now, this patient had come to us from the OPD. Obviously, he could not have received an IV bolus 2 hours earlier. Second thing is, if he was having oral dosage, we did not know, it did not fit into the trough level or the peak level. So therefore, we requested to recheck the timing, and we had to take the sample again. Having received the sample, having received the clarification, we processed the sample. Another problem can be the choosing the wrong phlebotomy site. For example, we received 2 samples from 2 different patients for serum electrolytes, as well and from one patient it was serum electrolytes, and from the other it was electrolytes, calcium, phosphorus, RFT, LFT. And in both samples, all the results were low, and they were both from the same ward. So we wondered what happened, and kappa. This is the example of the sample that came to us with such low values. And what happened is that root cause analysis revealed that both patients' sample had been drawn from the site of the IV cannula. And for one patient, of course, for the first example, there was an uncannulated vein available, and we were able to get a phlebotomy from the uncannulated vein site. And we got a fresh sample and we gave the appropriate result. But the second patient had IV catheters running, fluids running, drugs running, and none of his veins were available. So under such circumstances, what do you do? Does that mean you don't take a sample? It's not. You need to take a sample, and there are ways to do it. So in these situations, you have to be very clear that you must clamp the IV cannula for phlebotomy. You must withdraw about 5 ml and discard it, and then withdraw the blood sample in the appropriate blood collection tubes. Everywhere it will be BCT. BCT is blood collection tube, in case anyone has any doubt about that. So there are ways and means of overcoming each and every problem that we have, and one must just be aware of them. So this is another example of a patient, and we had this result that showed low calcium and magnesium, high potassium and a low alkaline phosphatase also. So we tried to do a history and examination were absolutely normal. This was a patient who came from the OPD and she walked in and she had no problem at all. So then what could be the problem? The problem was that the sample was taken in the wrong container. It was taken in potassium EDTA. And how does that make a difference? That makes a difference because it contains EDTA, potassium is likely to be higher. Because it contains EDTA and EDTA chelates calcium as well as magnesium. Therefore, your calcium and magnesium get lower. And alkaline phosphatase is also interfered with because it inhibits alkaline phosphatase. So, therefore, we have to be very careful about such situations. And while I'm talking about this, I thought I should tell you about what are the possible interferences with other tube types also. For example, with sodium fluoride and oxalate, you will have, because it contains potassium oxalate, potassium will be increased and it is not suitable for any not suitable for visualizing cells also, because due to efflux of potassium from the cells, it will just collapse the cells. Lipids will be significantly reduced in a fluoride sample, and even glucose can be reduced if it is standing for long periods of time. For example, there is a reduction of 5 to 7% per hour at room temperature, and room temperature is not our type of room temperature. Is 20 to 25 degrees is considered room temperature, and that is not available in all places in our country. ADA has proposed that these blood collection tubules for glucose estimation should also include citrate buffer. It should be a combination of EDTA and fluoride in a citrate buffer, and that causes immediate inhibition of glycolysis. So at least the purpose for which the tube is made is served, so that even if the tube stands for some time, there are some providers who have made these and some have not yet gone to that. With lithium heparin, sodium lithium heparin, we have dilution of the sample is the simplest thing, that is one. And the other thing is albumin is also low, not only because of dilution of the sample, but because there is inhibition of binding of albumin to bromocresol grain. And calcium is also low due to direct binding of heparin with calcium. And if you are doing a cryptoprotein investigation, then you must avoid this because heparin precipitates cryofibrinogen. It also slows some antigen-antibody reactions. So all your immunoassays should not be performed on heparin samples. The citrate PCT, of course, it inhibits platelet activation. And the basic thing is it has a 3.2 or 3.8% solution of trisodium citrate. And the ratio in which the sample is to be drawn is 9:1. That means the sample should be 9 parts and the citrate should be 1 part. It interferes due to chelation, and it also causes inhibition of all the enzymes, but especially of AST and alkaline phosphatase. Another problem that occurs often in the labs in the pre-analytical phase is a sample mix-up at the time of phlebotomy. So there was a time that we received 20 samples from one ward, and we received barcoded tubes, and barcodes are read directly by our equipment. But on uploading the results on the LIS, it was noticed that both the samples results did not match the prior trend of results that this patient had. So then we requested fresh samples, and fresh samples were received in process, and they were matching the previous results. Now, why this is a situation that has to be avoided, and to avoid this, what do we need? We must do what we need to do is we have to prevent it happening. And if it has happened, we should be able to identify that it has happened. So the first and foremost thing for prevention would be to make sure that we have a proper assembly and labeling of all the sample requirements before we get to the patient. This is for the phlebotomist or the nursing staff or whoever is taking the sample. The next thing that they have to do, the next thing is that once we are reporting, we should make sure that we do a delta check. And if somehow in her hurry or in their hurry, the phlebotomist, whoever is drawing the sample, has made a mistake, we should be able to pinpoint the mistake. We should be able to pick it up and immediately rectify it with a fresh sample, even though that is painful for the patient. but we should be able to do that much. And if we also miss it, and suppose the patient has come for the first time, we have nothing to cross match it with, the results, to cross match the results with. So then the clinician's role come, and he has to see, okay, is this sample matching what I expect? If it is not, we welcome clinicians requesting a fresh sample analysis. And sometimes the result is absolutely correct, but sometimes there has been a problem, and that is okay. The reason why we must make sure that such a situation does not occur is that it has grave consequences. With the wrong report of any sort of wrong report going, there may be mismanagement of the patient, in addition to tarnishing of the reputation of the lab or the institute. Another problem that often occurs is improper sample filling. So we received a sample, an adult sample for glucose estimation, and it came in the critical range of 42 milligrams. And the root cause analysis revealed that there was a clot in the gray top sample. So what was this because of? In this case, it was because of overfilling. And you can see that each of these tubes have a mark on their body, which tells you up to what point, this black mark that is there. Let me see. No, can you see my cursor? This is the black mark here. This is the black mark here. And this mark tells you up to what level you have to fill the sample. And all tubes have these markings. So please avoid overfilling. And again, we had a similar situation where the sample revealed a blood glucose of 32 milligrams, which is again critical, and we were perturbed. But again, root cause analysis showed us that it was, again, there was a clot in the gray top sample. And another sample received for APTT PT was found to be in the critical range. And here too, there was a clot in the blue top sample. And this was not because of overfilling, but this was because of improper mixing. And as you know, that each of these tubes has a proper way of mixing. For example, for the red and maroon tops, there is no inversion required. For the yellow top and the blue top, gentle, slow inversion, 3 to 5 times. For the purple, black, green, and light yellow top, it is 8 to 10 times gentle inversion. And this is not just something that I'm giving you. This every PCT provider gives a chart. We use BD Vacutainer, so therefore this is a chart that is given by BD. And they tell you exactly what to do for each sample, and they tell you how to invert it. A very major problem that is encountered almost, actually is not almost every day, but every day, and with a large number of samples, and that is hemolysis. And this is one of the major pre-analytical errors. And our root cause, we performed an exercise, a clinical audit on this, and we did a root cause analysis, checking all these features with how long was how well was the sample uh, drawing procedure? Was it done properly? What did the nursing staff do exactly? Or did they monitor the time allowed for clotting that was required? Then we monitored the process of transport also. We monitored the time lapse between the sample sample drawing and the sample received in the lab, and between the sample received in the lab and the centrifugation. So having ascertained all these things, we also analyzed what were the causes on basis of this root cause analysis. And this is what we found, with the maximum samples coming due to getting hemolyzed due to improper phlebotomy practices, or not allowing the sample to stand before transportation, and improper transport method. Intravascular hemolysis and friable veins also accounted for 11%, which was a large percentage, while improper processing within the lab, thankfully, was only 1%. So for this, we performed an exercise by which we trained the phlebotomists, trained the staff, and we continued monitoring our hemolyzed samples received for a period of 3 years, from 2021 to 2024. I know 2023 is written here. We were able to reduce the rate of hemolysis in our labs from 0.87% to 1.55% to 0.87% in 2023, and now it is 0.75% in 2024. The rate of hemolysis The Asian average is 2.82, while we were anyway less, but each sample that is hemolyzed is a problem. And therefore, we must try to achieve minimal hemolysis. Global average, of course, is 1.99, and we have achieved better than that, thankfully. And this helps us not only to improve the results that is going to the patient and improve the patient experience in the hospital or in the lab, but it also is a saving process because less material is used. Like you don't have to require a repeat sample, and less time of the people is also manpower hours is saved. So what about hemolysis? Now, why is hemolysis so important? Theoretically, the golden rule is that no hemolyzed sample should be processed. But is that always possible? There are many situations which I have mentioned here where it becomes imperative that we cannot get another sample. You have taken 3 samples from an ICU patient. His veins are hemolyzed. He has friable veins. There is no site that is available. Then what do? The report. He has to be treated at that point itself. And he has thrombosed veins. What do? A transplant patient has given you a timed sample for his tacrolimus estimation. You cannot take another sample after some time and say, okay, we'll process that because that by then he will have already had his medicine for the day. And then his whole report will be delayed another day. Similar is the case with methotrexate. So then every lab is encouraged to ascertain whether there are any urgent parameters that may be estimated without impacting the quality of the result. So this has to be done by everyone in their own lab, and we did that several years ago, and we published it. And what we did is that we found that a slightly hemolyzed sample, we were able to process BU and creatine amylase, surprisingly, amylase lipase also, and tacrolimus and methotrexate. And uric acid could only be estimated in a moderately hemolyzed sample, while as analyzed that can never be analyzed in a hemolyzed sample is phosphorus, sodium, potassium, total protein, and LDH. So how do you say what is moderately hemolyzed and what is slightly hemolyzed? So therefore, we made a chart for our purposes that this is the sample chart and this is the one in which you can take for this analyte. We made this readily available to our technical staff. Now, talking about your improper sample transport, you must know your analyte, and there are some that are heat labile. So during the COVID pandemic, we received a sample for IL-6, and the result was alarmingly high, 1850 picograms per ml. This patient had come walking in, he had not come to the hospital. He was walking around and he went home and gave his sample. And his only symptoms were just a mild body ache, and he was COVID positive. And this did not seem to be a correct result. So a fresh sample was requested. And definitely the fresh sample result was 56, which was high, yes, but not alarmingly high, and therefore did not require too much of intervention. The root cause analysis showed that this was a home collection. Sample was taken at 9 a.m. And this was the summer months, and the sample was received in the lab at 2:30 p.m. There was no cold pack, no dry ice, and for 5 hours the sample was exposed to 40 to 42 degrees centigrade. And that is not possible. This isn't a heat labile analyte. So what IL-6 can be stable for 8 hours if kept at 15 to 30 degrees, not at 40 degrees. And it can also be stored for longer at 2 to 8 degrees. So we must be all aware of our sample transport and our heat labile analytes. Similarly, sample transport is also important when you have samples like those for ammonia. We had a result of 320 micromoles per liter. And clinically, the patient was of hepatic encephalopathy, but they did not expect such a high result. So they requested a fresh sample analysis. And definitely, the result was lower. It was 210, and it was within the clinical expectations. And therefore, now, what was the reason for here? What was the reason for the wrong result in the first place? The first sample was drawn at 8:30 a.m. and reached the lab at 10 a.m. While as we know that every sample for ammonia and lactate has to be processed within 30 minutes, which means that it has to come to the lab within 15 minutes. And that is why only in-house samples are done for ammonia and lactate. We had one sample with very low results of all analytes. So we thought maybe it's an analytical phase error, and we found that there was a sample probe obstruction. Root cause analysis revealed that there was improper time of centrifugation. So therefore, we retrained our staff. But all samples that are collected in plain vials, with or without gel, need to stand for approximately 20 to 30 minutes. Nowadays, even 10 minutes with the new clot retractors, clot activators, sorry. And even after that, after centrifugation, there must be a visible an inspection, a visual inspection of each sample. And as you can see in the upper sample, the clot is very clearly visible. In the lower one, it is hardly visible, but if you have a good suspicion, then you will detect it also. So this is how we keep on training our staff also. And of course, these are the speeds of centrifuges that you require, and it may be different for different analytes also sometimes, and different for urine. And then if you're aliquoting the samples also, it has to be done very meticulously, taking into consideration all these points. To summarize, sample integrity may be affected at any point in the path of the sample from ordering to centrifuging and aliquoting. And we must identify the major causes in our own institute, in our own lab, and address them accordingly. And last of all, from the ordering clinician to the patient, to the phlebotomist, to the transporter, to the laboratory personnel who is receiving the sample, to the laboratory physician who is reporting the sample. They must all work in unison to prevent recurrence of problems. And we are all there for the patient, and it has to be a teamwork. We cannot work alone. Thank you very much. And I will escape and stop sharing. Over to you, Mamta.
Wonderful presentation. I'm sure all the attendees must have been greatly benefited by this. So now we have and we'll take up the question answers if there are any in the chat box, or if audience have any questions. So we will take up in the end. So now we have our next speaker amongst us, and Professor Atul Gogia. So Dr. Gogia, thank you very much, number one, for accepting our invitation and being part of this. And to the audience, I would like to introduce Dr. Gogia. Dr. Gogia is he's a senior consultant and head of infectious diseases unit at Sir Gangaram Hospital, New Delhi. He is also member of Royal College of Physicians, UK. And he has also done certificate course in HIV and trained in infectious diseases, members of the HICC, and he is reviewer of many national and international journals. And he has more than 120 publications to his credit, and authors of various medical and patient awareness books. Thank you so much, Dr. Gogia, once again, and over to you.
Thank you so much, Dr. Mamta, for the kind introduction. And it was really great to hear Dr. Seema and understand that so much goes behind the lab. Although, obviously, we are aware that without this lab support, the clinicians can't actually do. And actually, I reread, and tried to understand as to what my topic is. And and finally, I could, think of certain things. Is my screen visible?
It is visible.
Okay. So I try to understand as to what is happening and what are we supposed to do. So with that, I just put this slide here where you can, see the top view. I don't know if the lab people have actually got the chance to see this view, but if you go to the 10th floor and from the new building, and this is the view you get. So
yeah, we have. Thank you.
Okay. So as I also kept on thinking whether I should put this as my first slide or the last slide, which Dr. Seema said at the end. So this is a famous quote from Steve Jobs, that great things in business are never done by one person. They are done by a team of people. So you cannot actually work on patients alone. So you need a team effort, whether it is a team of clinicians, the lab people. And so it is an interaction which is there. And we are always, as clinicians, finding faults there. But then there are challenges there. So I have tried to get a few cases where we will be just seeing what we are looking as a clinician and what is the perspective and how lab is helping us or not helping us. So this is a very real case. It's been a few years back. This was an elderly lady. I used to do evening clinic and in the hospital, and it was late in the evening. I was in a thing to go home, but it was past 8 o'clock. She's sitting outside the OPD. She's altered. She's lethargic. She's having weakness, constipation, which has been going on for a few days. So with these kind of complaints, she comes into my OPD chamber, and she's getting a whole lot of investigation. So this is what I'm trying to highlight here. She's got all the basic investigations where you have done a complete blood count, you've done a renal function, liver function, urine routine, everything. And apart from whatever I could go through all the reports, the only report which I found was that she had a mild anemia, which was an 8.4 grams of hemoglobin, which was microcytic. And rest of the reports, they were just a mild renal dysfunction with a creatinine of around 1.8. The rest of the mild hypoproteinemia, and most of the other reports were within reasonable range. And as she was altered, lethargic, so the clinician outside evaluated them. They did an MRI scan, they did the X-ray, ultrasound, everything actually was done, and nothing conclusive could be reached at. And that is why they start thinking of coming over to the hospital. So there, when I saw this patient, so I clinically saw that she has some metabolic thing which is going on, and which we are not able to pick up, but she was carrying all the reports. So this is where the importance of the investigations lies. So without an adequate help of a lab, I could not actually reach to a diagnosis. So I managed to admit this patient, and we could get the basic investigation done. And she got admitted late in the night. And early morning, first thing when we saw this patient, there was a stark difference in the report, and the patient had a calcium of 13.1 with a creatinine of 1.9. And so the calcium was so high that could explain everything which was going on. She could be lethargic, she could have had loss of appetite, she could have constipation. So now our next step was as to correct the calcium and to look for what was the cause behind the high calcium. So this is just a small example how we are looking at investigations, and simple investigation like a calcium level, which is so routinely done. And if we pick up the hypercalcemia, and eventually in the next couple of days we could diagnose the patient to have a sarcoidosis, a pancreatitis, and all that, because of which she was having the hypercalcemia. We could correct that, we could salvage the patient, and she went home and she lived for another 7-8 years, and she recently passed away. So I still remember this patient. So it's a very simple thing like a calcium test. If not done appropriately, or any lab, they can be misleading, and they can cause a challenge to a clinician who's solely dependent on clinical sign symptoms. Apart from that, lab support. So going on to another case scenario, where this is a 50-year-old gentleman who has COPD, has rheumatoid arthritis, is on disease modifying agents for that, comes into us with fever, weight loss, cough, breathlessness of 1 month duration, is evaluated outside, and is admitted in a hospital somewhere in Greater Noida. is extensively evaluated, and on evaluation is found to have features suggestive of chest infection, or for which he undergoes a bronchoalveolar lavage, and he's found to have a gene expert for MTV positive. So the advancement of tests like gene expert make things much easier. So this patient is diagnosed instantly to having TB. Then the other thing is that the patient's BAL galactomannan is also positive. So that is also significantly positive, more than one which is positive. So that is also an innovation which is there, a lab test. Otherwise, earlier radiologically, you would be seeing this patient, you would think of tuberculosis, you sometimes may not get a smear positive for the AFB. So gene expert technology has really helped us in instantly, within hours or maximum a day, we get the report, and we are able to know that whether this patient has TB or not, and whether there is rifampicin sensitivity or not is there. So that really has changed our diagnostic process, the management process also immediately. This was BAL. In the CSF also, we have been having very good results with tests like this. The other tests, which again, galactomannan is another contributory test, but yeah, that also, in the case scenario like this, we would, if not done this kind of a test, we would have missed an aspergillus infection, which is it suggestive of, which can be there in an immunocompromised patient who's got rheumatoid, COPD, who's often on steroids, on immunosuppressive drugs. So there, now the story here is that with these good diagnostic tests and challenges the labs are offering, we could a diagnosis of a dual infection was made in this patient, and patient was started on anti-tubercular treatment as well as voriconazole. And despite this, in the next few weeks, the patient was not improving. So the patient landed up with us as to not having the complete resolution of symptoms. So for a second opinion. So there also, as a clinician, you have to understand that lab has done a wonderful job, but we have to go hand in hand. So rifampicin and voriconazole have a drug interaction, so which was probably not thought of outside, and we have good lab support here. And so in our lab, when the patient came in, we did his voriconazole levels. So we found that his voriconazole levels were haywire. His rifampicin levels, which I have been telling my labs to do, were not able to done, but we modified his anti-tubercular treatment. We removed the rifampicin, we modified the dose of voriconazole, and within we could tell the patient that this is the issue which is happening, why you are not improving. So patient was also convinced, and the next couple of weeks, following weeks, patient started showing recovery. Patient came to me just a couple of days before. Patient is having weight gain, fever is subsided. So simple tests and doing them appropriately and clinically understanding this. So this is very, very important. The drug levels which are being done wonderfully by the lab are also very, very important, because it is very, very common interaction. Voriconazole is one of the most commonly prescribed antifungals, especially in the transplant setting and in patients who are nowadays on a lot of immunomodulatory drugs. So it is very important that we do these kind of drug levels as to appropriate level is to be achieved. There are a whole lot of other azoles also for which we need drug levels, but sometimes we are looking for labs which are not doing, or the turnaround time is a problem. So that is the problem. Probably they have their problem as to not getting the kind of samples, the number of samples required. So itraconazole is another drug for which we need management of itraconazole is something also for which we need levels, because a lot of fungal infections, histoplasmosis, where these drugs are used, and we need to monitor the drug level. So it is very important, and the lab support helps us because we are able to get the right level, and that translates into patient improvement, clinical improvement, which goes in a long way. So this is a small case scenario, which is a very common case scenario. So this is a dengue season patient who has clinically dengue, fever, body ache, headache, weakness, 35-year-old, to do a basic examination workup. He gets admitted in the middle of the night, and you do a blood count, and you find out that the HB is high, the PCV is high, and the platelets are 8,000. There is a lot of panic concern because of this as to why the platelet is very low, although patient is not bleeding, but because 8,000 is very low. So here the fallacy comes in, especially when, and then when you do run in the morning and you do a smear examination and you find out the actual platelet count is 18,000. And so there is a lot of panic which comes with this. I don't know how the labs can work on this, but this is something because there is a lot of clumping or the machine is not able to pick up. So that kind of a problem is there, which causes a problem for a clinician. But overall, I would say that there are molecular tests which is more and more coming in, and more are helping it. But we need to rethink and think how it works, because we have to apply our minds and not just leave it on these molecular tests. So this is a patient who's admitted and probably discharged yesterday only. This is a 65-year-old lady. She gets admitted with orthopedics, has a chronic osteomyelitis, features of chronic osteomyelitis. A surgical excision and drainage is done, and a multiplex PCR, which is a joint infection panel, is done. And the PCR picks up all these organisms. So half of them, most of the people have never heard of or can actually spell or pronounce them. It's Aeromonas, Fine Goldia Magna, Klebsiella, Peptostreptococcus. So if you see, so you have to see the clinical scenario and understand which is the actual organism which could be causing it. And so there's this interpretation and a talk between the clinicians. So this is where discuss with the microbiology lab. So as to what should be done and what is the positive cost. So going back to the history, examination, discussion, and the possible organisms causing this kind of, we shortlisted into 2 causative organisms, and we could tailor the therapy of this patient accordingly. So it is very important that we apply our mind, the clinical history, examination, and collaborating with the lab. Although we have a lot of technology coming in and a lot of new tests coming in, but it is the amalgamation of these and a discussion with the lab to come as to what could be the cause. So it is very important that we have, what as a clinician we are looking is something which is accurate, precise. So if you see what is accuracy and what is precision. So the blue dart is precise, but it's not accurate. And the red dart is both precise and accurate. So we're trying to achieve what this with the help of going hand in hand. And that has to come as a like a bullet train speed. We want, as a clinician, what are you looking for? The shortest possible turnaround time. So you have to be getting these tests done as fast as possible so that they can have a meaningful clinical relevance, and the maximum benefit is there to the patient because of these tests. So the collaboration is the key. If you see, there is to be discussion, interpretation. There may be false positive, there may be false negatives, but I think whenever in doubt, go back to your lab doctor, talk to them, and a clinician. Both ways should interact, and a lab doctor should call a clinician wherever they feel that something is amiss or something is a buzz that needs to be fixed, and reach to a better diagnosis. That is what is important. So it's thanks to the lab people for all the understanding, because actually if you see, they are what our stars are. So these are our superstars the directors, you know, and our lab directors. They are our superstars, and as you see, all the superstar, right from Steven Spielberg and all, you are the people who are there. Without them, you know, we can't do anything. Unless and until you direct us, give us the right direction, we can't reach to a diagnosis. Thank you so much. Thank you.
Thank you so much, Dr. Gogia, for giving a wonderful presentation, and all the cases which you had presented were really very good, pertinent, and the way you have highlighted that how labs can be of use and what more is required from the labs. So thank you very much once again. So there are a few questions in the chat box which I would like to take up. One question is for Dr. Seema, that heparin tube is suitable for ionized calcium test or not?
Yes, it is suitable. Though when you do it for a routine calcium, it interferes with the calcium. Sorry, what is it blocks the bromocresol green and I'm sorry, that is albumin. But for ionized calcium, it is acceptable. Heparinized sample.
So this next question is for that there is any other test for extrapulmonary TB which clinicians order other than gene expert, Dr. Gogia?
So actually, Gene Expert has actually really changed the way which we diagnose TB, because it's really good and it is really fast. So it is really a good test. But apart from that, the other are the conventional histopathology, cytology, depending on the site, or the conventional AFB smear. These are what the standard tests which we generally would do, apart from the Gene Expert. And obviously an AFB culture, which is still the gold standard. But the only problem with an AFB culture is it takes a lot of time, but it is helpful. I'm telling you, in the last 1 month, I have had 2 patients. One, a VIP patient, admitted with fever, weight loss, although the fever settled, but she was having weight loss. She had a very tiny nodes. The nodes were FNAC. Everything was negative. The Gene Expert was negative. The smear was negative. The lab just could show, the cytopathology people could just see anthracotic material. But to our surprise, after 2 to 3 weeks, MTB complex grew on the culture. So only 2 days back, I have written anti-tubercular treatment to that patient. And there was another young fellow who was running around, 18-year-old, with a parotid swelling, running all across, come all the way from Bihar to Delhi. He's been running here and there. Somebody's told him he's got a tumor, something. Finally, he came to me with a positive MANTU test only. And I told him that we do a repeat biopsy, and repeat FNAC was done. There was some granuloma. So my clinical impression at that time was probably it was a sarcoidosis. But to my surprise, Gene Expert was negative. Everything was negative. And after 4 weeks, the swelling is but the MTB grew. So AFB culture is also very important. Yeah. Sorry for taking so much time.
No, that's perfect. And one more question to you is that in routine, I understand that you're in this hospital and you face less problems. You're able to interact with the laboratory people. But in general, what other problems do the standalone physicians have to come across in terms of coordinating with the labs and getting the result that they want from the lab?
So I think the main problem is, as a lab person who's standalone, they do not have any clinical input also to that extent. So I'll just give you a small little example. This gentleman who's got a skull-base osteomyelitis sitting with me just before this webinar. So he had a CT scan done of the skull in September in Gangaram Hospital, right? So he came to me a day before and I told to get a repeat scan done, right? So this time, for some reason or the other, he went to a lab outside and got a CT scan done and came back to me with the report today. So now his input was also there, and I had also. The problem was that they had no clue as to what's happening. So their technician there or clinician is not able to interact with them. He's asking, what is your history, trying to understand. So the problem I feel with the clinician, lab doctor in a standalone is that there is minimal interaction. They are not aware about the proper clinical input is not there. So probably if I give them a more clinical input, they can probably give better results. I think that is the only major concern. So I just, the first case which I tell you, this lady, for altered sensorium, she had undergone every possible test. She's seen a neurologist, she's seen everybody, and then she comes up to me because, and the calcium was 13, and we corrected her calcium in the next 2-3 days, and she became conscious and fine. So and she had done a test outside in a reasonable lab. You go to a reasonable lab close to her house. She's staying in East Delhi, in Delhi. So I think the standardization of the lab and plus interaction of the clinician with the wherever there is a little bit of doubt, or wherever there should be interaction, which is, I think, missing.
Yes, that's really true.
That is true. Thank you. Thank you. For that.
Another question for Dr. Gogia, that you have, being a clinician, you must be getting patients from all over India, or North India especially. So like from rural areas also. So what difference, am I audible?
Yes, ma'am. Yes, Dr.
So what difference do you see when you see that they come with the reports from some lab where tests are being done in the rural area, lab is not accredited also, or there is no doctor also, biochemist, pathologist, microbiologist, anyone. So do you find difficult, in such situation, what do you do? Do you rely on those
Obviously.
tests?
Obviously, it is very difficult, as I told you, without a good lab support. Making a diagnosis in current days is it's an era of evidence-based medicine. It's not like 20, 30, 40 years ago, where I would, internship days, you are not having that much of lab facilities. You are doing only on clinical basis, or so now you need evidence, and there are so many tests which can actually help and benefit the patient. So if you are not able to get the appropriate result, you are not able to treat appropriately. So it becomes a challenge. Cost becomes a challenge for a lot of patients who are coming in from rural or semi-urban areas, where so the question asked to a clinician by a patient is कि कौन सी lab से test कराएं डॉक्टर साहब. So what is the answer to it? Get it from a good or an accredited lab. That is the only answer one can give. So that is the only way. If it is an unaccredited lab, it does not have the appropriate person, or a pathologist, biochemist, or a microbiologist, then you can't have a good report. And that on basis of that is what the treatment is going to be. So if you do not get the right report, the diagnosis and the further treatment becomes a challenge.
Difficult when people are not getting good facilities, diagnostic facilities. So that is very important.
That is very important, yeah.
So another question for Dr. Seema, next question. She presented a study on hemolyzed samples. So one of the participants have asked that what about, you have conducted studies on many tests. What about the tests which are being done in emergency, which are required for emergency, like HS-TROPI, NT-proBNP? Can we rely on, have you done any study on those particular analytes?
Yes, we did. Unfortunately, we cannot use just hemolyzed sample to estimate HS-TROPI or NT-proBNP. Very unfortunate, but it does not give accurate results. So we cannot do it. I'm sorry about that.
So last question for Dr. Gogia, that when in one of your presentation, you said that you have been requesting lab for starting these tests. So if the test is not economically viable for the lab, so how does lab address to it? How do they sustain that? They want to offer the services, but if the economical viability is not there, so then
I know
because
that will be
we
there
are not
whenever you are
government
starting a
hospitals.
new test. Whenever you are starting a new test, that will be a challenge. I'm sure that will be a challenge. But I think you've seen majority of the tests which you've started so far, eventually over a period of time, they become economically viable because awareness
Many
has to
more
be there.
sites.
So one number, and the other thing is, for a lab like ours, if we are the only one, or there are only a couple of labs like us who are doing it, so you start getting, one, the awareness is there. So if my specialty or the other specialty, people would ask me that you are doing this test, where do you do this test? So I can tell them that our hospital is doing it. So right now I have to look out for some standalone lab or some lab outside which is doing. So simple tests like rifampicin levels, which are being done only at a couple of places, only one odd places are doing it. So if we are able to project that we are the only one who are doing it, so we'll start getting samples from different places. So that is the only way. Initially, definitely, I am sure that there will be a glitch that you may not get that many samples. But I am sure that after a few months, when the awareness increases, so it will become commercially viable. I know that is a challenge. The costing of the test will also be changed. That's what the other hospital is doing.
Initially.
I've heard a word there, is that they have kept the costing initially was higher, but now the turnaround time is also better, and because that is the only place which is doing it.
Yes,
So
that
there is
too. And I remember sorry, Mamta, I'm just butting in, but I remember our previous HOD, Professor L.M. Srivastava, used to say, you have to go through these non-profitable tests at the cost of the profitable ones.
yes,
You'll make up in that. The patient needs it, you should go ahead for it.
But
Yeah,
this is laboratory and to the clinician, because you are representing clinicians today, that laboratory feels very happy and excited when clinicians request for some test or they themselves introduce some test for patient care, some new test from there and only. So thank you very much. And
thank
thank
you.
you very much for being with us. And I now request Dr. Seema Bhargav, HOD, Department of Biochemistry, to give vote of thanks.
Thank you for that introduction. But first of all, I'd like to thank ACBI, and that is Dr. Indu Verma is the president. She is the professor and head of biochemistry at PGI Chandigarh. I would also like to thank Dr. Rajiv Ranjan Sinha, who is the General Secretary of ACBI and is also the head of Department of Biochemistry at Nalanda Medical College. Dr. Praveen Sharma is with us, and he is one of our guiding forces. Thank you, sir, for joining us today. And my whole team of Delhi chapter of ACBI has been, we thank ACBI for giving us this opportunity, but we are doing it as an ACBI venture. But the whole team is involved in it, is my point. And so thank you to the whole team of DC ACBI. Thank you, Dr. Prasanjit, for your very, very proactive, despite all the glitches that I faced today. Thank you for being there for me and for helping me out, and also for setting up the whole Zoom link and everything. Dr. Gogia, the most important is thank you for being with us, for agreeing with us, for agreeing to join us, because without a clinician, our work is incomplete. We must have the feedback of all our clinicians, and only then can we progress further and improve once we know what more is expected of us. I would also like to thank all the audience who have joined us today, who have taken out time and joined us today. I hope it has been fruitful and educative to some extent. And we hope to see you again very soon, next month maybe. And thank you. Thank you very much.
Thank you.
Thank you very much. Thank you, everyone.
Thank you,
Thank you,
everyone.
entire ACBI team and all the audience. Thank you, sir.
Thank
Thank
you.
you, ma'am.
Thank you, Dr. Gogia, for a wonderful talk. So it is really good initiative. So let's continue with this. Thank you so much.
Thank you.
Thank you, ma'am.
Thank you.
Thank you, everyone.